We'll get started. Okay, good morning. So, yeah, you guys need to get on the road. Traffic's bad anyway, but if you get on the road before, 1 or 2 o'clock in the afternoon, it'll be a lot better for you guys that are traveling. So, welcome back. It's been a busy, full week, right? But hopefully it's been some fun, some good food. And myself and a couple of my colleagues went over to Nantucket last night, and I have not eaten that much food in forever, but it was so good. All right, so we're going to talk about surgical site infections this morning. Again, the good news is, for those of you that have been doing surveillance for last year, there's not a lot of changes. There are a few additions, but no real major changes to the definition, so we're going to go over some of those, I think. Oops. My battery might be dead, so let's just do it. Do that, wake it up, okay.
See it go now.
Let's see if it can.
Really? I don't know. It's been.
Will this work?
It's just gone crazy on me.
Okay. So maybe the computer doesn't like Friday morning either.
It seems not to. It's
Yeah.
kind of sleepy this morning. It wants to take the weekend off too.
Right.
Maybe it's tired from the case studies.
I know, it's kind of like watching a pot boil, isn't it? There it is. There we go. Cool. Good.
All right. Yeah.
Perfect. Okay.
All right. We'll start again.
Good job. Good job. All right. So just to let you, or to remind you, that the definition for present on admission does not apply to surgical site infections. So don't, when you're working with SSIs, don't even think about present on admission, okay? So in-plan surveillance, and I think we talked about this earlier in the week, just to remind you that if you put in your reporting plan for NHSN that you're going to monitor surgical site infections other than colons and abdominal hysterectomies, which you're required to do according to mandatory reporting, then you do have to follow that protocol in its entirety. So there may be some additional data elements that you do not normally collect that you would be expected to collect if you're going to submit that to NHSN. Some of those are like if you're doing C-sections, knees and hips, and I know South Carolina has to do knees and hips because of their state reporting. Fusion and refusion, there are some additional data elements that you would need to collect if you put those in plan. Off-plan just means that you can do your surveillance per your surveillance plan within your organization, and you can collect the data elements that are necessary to report out within your facility. So this is one of the things that NHSN, it was a little confusing at first because they were going to change their rule about inpatient versus outpatient surgeries, and then they realized it was creating quite a bit of confusion, so they went back to the old methodology, which we had in place last year. So basically at NHSN, operative inpatient is a patient whose admission and discharge dates are different. So they can be admitted on Monday and discharged on Tuesday, and that is an NHSN inpatient, regardless of how your hospital or facility categorizes it. So an outpatient, NHSN outpatient procedure would be that procedure where they are, their admission date and their discharge date is the same day, okay? So it doesn't have anything to do with how your hospital categorizes them for our purposes. And then in one of the definitions for superficial surgical site infection, we talk about aseptically obtained. And, I always considered that they actually cleaned the incision good, or they aspirated fluid from the incision, or we made sure that we weren't just culturing the gunk up on top of the incision. But when I was in Atlanta last year, NHSN basically just said that if your specimen is sent to the lab, if you collect a specimen and it's sent to the lab and it identifies an organism, then you should count that. So you don't have to try to research necessarily how that specimen was obtained. So their definition is that it's obtained in a manner to prevent introduction of organisms from the surrounding tissues into the specimen being collected. But again, if your lab accepts it and reports out an organism, then that will count as aseptically obtained. So trauma, again, those are some questions that you're required to respond to on certain procedures. And trauma doesn't mean they have to be in an automobile accident. They can fall off a ladder and break their hip, and that's considered to be trauma. So in that case, if you know that level of detail, you would want to check yes for trauma. So basically, it's blunt or penetrating injury. So it doesn't have to be like we think about a trauma center or automobile accidents or gunshots or those sorts of things. It can be any sort of blunt or penetrating injury. And then the scope is an instrument, obviously, that's used to visualize the interior of a body cavity or organ. And you can have several small incisions, and this is included in our NHS and surveillance if they have laparoscopic procedures. So some of the basics, if the patient has a stitch abscess, that is not considered to be a surgical site infection, so do not include that. And usually you can determine that by the description of either the surgeon or whoever's documenting that site that it is a stitch abscess. And so we do not need to report that. If it's a stab wound, then that is not reported as a surgical site infection as well. So if they did a stab wound to place a drain and there was some irritation around that site, then that's not considered to be a surgical site infection. And then cellulitis by itself does not meet the criteria for superficial, yes?
In regards to the stab wound, I have a procedure that we do that they pull a drain through one of the laparoscopic ports. That's not a separate stab wound created for the drain. They actually use that site during the procedure. So I could report that because that's used during the...
That's correct. So her question was that in the laparoscopic procedure, they use one of those trocar entry sites to pull the drain through, and then that would be considered a site that you would look at for SSI. It is not a separate stab wound. And then cellulitis by itself does not meet the criteria. And this is one of the problems we have with trying to get post-discharge surgical site surveillance data, because oftentimes surgeons may say it's cellulitis or inflammation and not describe it really well enough for you to make the determination as to whether it is a surgical site infection or not. Circumcision is not an NHSN operative procedure. There is another infection category, if they get an infection there, that you would report it under, but it's not under surgical site infection. And then same thing with burns. If you have an infected burn wound, then that's reported under the burn category in the other site-specific surveillance. So the 2015 definitions, an NHSN operative procedure is a procedure that is included in Table 1, and in the protocol, those are pages 9.3 through 9.8, and those are defined by a group of ICD 9 codes and CPT codes. If you have an ambulatory surgical center, or I know in certain hospitals, they will build their surgical procedures based on CPT codes rather than ICD-9 codes. And then this year, the ICD-10s are coming eventually, I think. And it also takes place where at least one incision, including the laparoscopic approach, is made through the skin, the mucous membrane, excuse me, or you have a reoperation via an incision that was left open during a prior procedure. And it takes place in the operating room. That's defined as an area that meets the FGI or AIA criteria, and AIA's kind of gone away, for an operating room when it was constructed or renovated, and this may include your cardiac cath lab, your C-section room, and your interventional radiology room. So I don't know how you collect your data on your surgeries. A lot of facilities that I work with, we get a report of those procedures that are done in the operating room itself, It's a little bit harder sometimes to capture all those procedures that are done in cath labs and interventional radiology. And if you're going to do surgical site infection surveillance on those, you need to be sure that you can collect the denominator as well. So you don't want to just get the numerator. You need to be able to collect the denominator from those areas as well. And then just a reminder, up until last year, the way the incision was closed had an impact, and that is no longer part of the NHSN operative procedure definition, incisional closure. All otherwise eligible procedures are included regardless of the closure type. So this is a nice little graph that one of the NHSN sons actually drew for her. She said she was trying to demonstrate what primary versus non-primary closure was, and so he did this for her. So before, this is kind of what we thought constituted primary closure. And before, if it had any openings, then we considered that not to be primarily closed. And then last year they changed that and said if any skin edges are approximated at any point in the incision, then we would consider that to be primarily closed. And it's only when the entire skin edges are open, left open, that it's considered to be other than primary. But for surgical site infection surveillance, you will include both of those, and there is a place where you will document whether it's primary closure or non-primary closure when you enter that information into NHSN. So this is a little bit of a change over the last couple of years as well. The duration of the operative procedure time used to be from when the incision was made until basically the incision was closed. So because they had to change, or they changed their methodology about primary closure, where the patient can actually leave the OR and not have closure of that incision, they modified their start and stop times as well. The start is still when the procedure is begun or the incision is made, but the finish time now is when all instruments and sponge counts have been completed and verified. Any studies that would be done on that patient, radiographic studies in the OR, have been completed as well. And then all dressings and drains are secured. So basically when all procedure-related activities are completed. This does not necessarily include anesthesia time, however. So when you work with your OR to try to get them to include that time, just make sure they understand it's when all procedure-related events are completed that are related to the surgery itself. And that's the time we want to use. So diabetes is a field now that we have to complete. Last year they kind of gave us a little break on that and said you could just kind of default to no unless you knew the patient had diabetes. This year they want us to either use their definition of diabetes, and that is those patients that have a diagnosis of diabetes requiring management with insulin or non-insulin anti-diabetic agent, or they have some ICD-9 codes that if you want to look up, you can use those to indicate whether the patient does have diabetes or not. And if the patient is non-compliant with his diabetes, that does not impact this, this factor. So you would always want to just double check. Probably the easiest way is to look at those codes if you have access to them. The height and weight are required on all patients, surgical patients that we send over to NHSN now. And they really want the most recent one. So if the patient's been in the hospital for a week or a month before they have their surgery, they want you to go back and try to find that most recent height and weight, and not necessarily the one that they had when they were admitted to your facility. The date of event, you know, we've talked a lot about that in our other surveillance definitions. Well, that for surgical site infections is the date that they have that first symptom. Excuse me. That they have that first symptom that meets the criterion for the surgical site infection. during the surveillance period, whether that's your 30-day surveillance based on your procedure or your 90-day surveillance based on your procedure. We already went through the secondary bloodstream attribution period. It's a little different for surgical site infections. Remember, it starts the day of the event, goes 3 days before, and 13 days after for a total of 17 days. Yes, do you have a question?
Yeah, so if I have somebody that has surgery on May 1st,
Mm-hmm.
they come back in on May 15th to the doctor's office and it's a superficial infection.
Mm-hmm.
But then let's say on May 25th, they come back in and they have an IND, it's still only counted as a superficial, it doesn't.
Okay, so her question is, if the example is if she has a patient on May the 1st that has surgery, on the 15th they have a superficial infection, and then a week or two later they come back in and have to have an IND. So if the IND at that point in time meets the definition of a higher level of surgical site infection, then you would call it at the higher level. If they did not have any invasive procedure done on the 15th when you diagnosed them with a superficial. Okay, so during that surveillance period, if they come back and they have a higher level of infection and have not had an invasive procedure in between those times, then you call it at the highest tier. So this is one of the new elements that, and I actually like this PATOS, where you now have the opportunity to indicate if there was an infection present at time of surgery of the original procedure. This doesn't impact every procedure, but certainly your appendectomies, your colons, some of your hips and knees that come back in with a prior infection. So it gives us the opportunity. You still have to write them up if they get a surgical site infection, but now you have the opportunity to let NHSN know that their risk of getting an SSI was greater because they already had an infection at the time of that surgery. Now, there's a little bit of, parameters that have to be met here. That documentation has to occur preoperatively or intraoperatively. It cannot be postoperatively. So in other words, if a patient comes in with a ruptured appendix, in the operative note, the surgeon has to indicate that there was contamination, an infection present at the time he went in and did the appendectomy. Okay? So preoperatively or intraoperatively documented. And then the other thing that is a little problematic, if that patient comes back with a surgical site infection and they did have an infection present at time of the original surgery, the infection at the time of the original surgery and the SSI have to be at the same level for you to be able to check PATOS yes. In other words, if they come back in with an organ space SSI after having a ruptured appendix, then you would check PATOS yes. If they come back in with a superficial surgical site infection after having that appendectomy, then you would check no. So the infection at the time of the original surgery and the infection level at the time of the SSI have to be the same. Okay? So these are some procedures that cannot be coded as clean, and if you try to send them over, if you have an electronic system that downloads your surgical information into NHSN, and if somehow they've been coded as clean, then NHSN will reject those. And those are appies, billies, cholecystectomies, colons, rectal resections, small bowel, and vaginal hysterectomies. So if by accident, I don't know how your OR works, but oftentimes those wound classes are still not accurate, and a lot of things will get coded as clean that really are not clean procedures. And if it's any of those that go to NHSN, they will reject those. Now, based on C-sections, abdominal hisses, or ovary-type surgeries, other female reproductive classes, they can be a clean wound class based on the particular events and findings. So you really need to work with your OR staff if you think you're having issues with the way your wounds are being classed. So we heard about this last year. It didn't happen. This year, we're still on schedule for this to happen, so we'll see. CDC continues to work on the updated ICD-10 codes and mapping to their NHSN operative procedures. Does anyone know if those mappings did come out in March? I honestly don't know. The new ICD-10 mappings, they were scheduled to come out, not in NHSN, but to be rolled out in March of this year. I haven't seen any information that they have been rolled out yet. But in any event, those codes will replace the ICD-9 codes in October, but NHSN will not have the ability to upgrade their system and receive those codes until January of next year. So basically what that means for you is that you will not enter any ICD-10 codes into NHSN for 2015. You'll just put the procedure abbreviation or the kind of procedure that you're putting in, but not try to enter a code. Okay? So denominator reporting instructions, and I think sometimes we don't think too much about that, especially if we have an electronic system that captures our denominator information for us. But these are some little tidbits that you might want to go back and refresh your memory on. So if you have more than one NHSN procedure, like if they do a cholecystectomy and a gastric resection at the same time, and they're done through the same incision at the same time, use the same start and stop finish time for each procedure because they're not making another incision, okay? And then if they have two different NHSN operative procedures performed via separate incisions on the same trip to the OR, try to determine the correct duration for each separate procedure if documented, and then otherwise take both of those procedures and split it evenly between the two. So this might be if they do a hip and a knee, do one hip and one knee, or do two different procedures using two different incisions. If you can't clearly discern from the OR record when one started and stopped, then take all of the time that they were in there and divide it equally between the two procedures. And then if they have the same NHSN operative procedure via separate incisions, indicate the procedure start time to finish time for each procedure separately, or again, take the total time and split it. So this might be if they have two knees. If they have bilateral knees done and you can't discern when one started and stopped versus the other, then take the total time and split it. The patient that is taken back to the OR during the first 24 hours after his index surgical procedure and his primary incision is opened and they do something else, you would combine that time that it takes to do that with the time of the original surgery and add those together. Now, I'm pretty certain that's not happening because that's just a lot of detail that sometimes we don't even capture. For instance, if they have a colon in the morning and they think they've got a little bleed or something later on that afternoon or night, we might not even recognize that they went back to surgery that second time because we might not capture it. But in the event that you do, this is what NHSN wants you to do with that information. If they open that same incision and do something else, take that time and combine it with the original procedure. So I'm sure Dr. Weber showed you this. This is a nice little schematic that helps us discern superficial layers versus deep versus organ space. So the key with superficial is that it only involves the skin and the subcutaneous tissue. If you see anything in your operative note when they go back to the OR that the fascia was not intact or it went below the fascia and the muscle, then we're getting into the deeper layers. And then when we actually get past that level, we're down into the organ space, SSIs. And as we'll talk about a little bit more later, if we call it organ space, it not only has to meet the definition of an organ space surgical site infection, but it also has to meet one of those organ space definitions that are identified in your protocols. So for the superficial definition, that is an infection that occurs within 30 days after any NHSN operative procedure. Day 1 being the procedure day. Now, when they say 30 days, they mean 30 days. They don't mean a month. So you actually take the date that that procedure was done on and you count, and on day 30 is your cutoff period. Now, one little caveat, if you've got documentation that they had symptoms that meet your criteria before day 30, and they just happen not to get cultured or into your facility until day 31, you still count them. So you look at when that infection, that first evidence of infection that meets your criteria occurred. And if it's on day 29 or 28, you count it. If it's on day 31, you do not. Again, superficial only involves the skin and subcutaneous tissue of the incision. And you have at least one of these criterion that are met. Purulent drainage from the superficial incision, and I actually like to see some sort of documentation where they actually use that word. Serous sanguinous does not meet that definition. So look for documentation where they actually use purulent, or they use pus, or something else that's kind of equivalent to that. So that's one. If they have that, that's all you need. Or you can have an organism isolated from that aseptically obtained culture we talked about. Or the surgeon or attending physician. So they did last year clarify that. And that actually can be somebody in the ED. It can be a hospitalist. It can be whoever that attending professional is. Opens that incision, and the culture is either positive or not cultured. So if they go in there and they culture that incision and it's positive, that counts. If they don't culture it, it counts. But if they culture it and it's negative, it would not meet your criterion. They also have to have pain, tenderness, localized swelling, redness or heat, which is probably why the attending physician would have opened up that incision anyway. But if the culture is negative, it does not meet that piece of the criterion. And then the last one is diagnosis of a superficial incision by the surgeon or attending physician. And again, that can be the ED provider, it can be the PCP, the primary care physician, it can be any attending physician that makes that diagnosis. For surgical site infection, this is the only tier that a physician's diagnosis is going to meet the criterion. So if you have some doctor who's documented in the note, and that's all you have, that this patient had a superficial surgical site infection, there still should be some corroboration that evidence of that infection was present, like he hopefully will document redness, erythema, drainage, whatever. But this is the only one that we can use the surgeon's diagnosis for. But we don't really have much of a problem with surgeons diagnosing surgical site infections very often. It's not often that we see that documentation. So for deep, remember now we've gone past the subcutaneous tissue and we're down into the fascia. So for a deep incisional, that infection can happen between 30 and 90 days depending on the procedure you're doing surveillance on. Again, procedure date is day 1, and it involves the deep soft tissues, fascial and muscle layers of the incision. And then you have to have at least one of the following: purulent drainage from the deep incision. The deep incision spontaneously dehisces or is opened by the surgeon with some of those same symptoms. Again, if the culture is obtained and it's negative, you cannot use that piece of the criteria. And then the last one is an abscess or other evidence of infection involving the deep incision is detected on anatomical or histopathological exam or imaging testing. So if they have a CT that says they've got an abscess, then that would meet your definition for deep. For superficial and deep, you're going to be asked to identify whether it's primary or secondary. And that comes into play if you have 2 incisions made. Did that infection occur at the primary incision or at the secondary incision? So that is not for, obviously, for every procedure, but for those that have 2, you will need to indicate that. So organ space, we're now down into an organ space or much deeper with our surgical site infection. And again, that can occur within 30 or 90 days based on the operative procedure that you're following. And it involves any part of the body deeper than the fascia, the muscle, that is opened or manipulated during the operative procedure. And one of these criterion have to be met. So they can have purulent drainage from a drain. They can have an organism that's isolated from an aseptically obtained culture. And in most of these patients, they're either going to be back in the OR for that culture to be taken, or it's going to be a CT-guided aspirate. So we're pretty comfortable that that has been obtained in the right manner. Or they can have an abscess or other evidence that's found on anatomical or histopathological exam, or again by imaging test. And again, remember, if it's organ space, they've got to meet those criterion, and then they've also got to meet at least one criterion for a specific organ space infection that's listed in your protocol in Table 4. Under the surveillance definitions for specific types of infection chapter. That's a mouthful. So these are the procedures that you can do 30-day surveillance on. So on day 31, if they didn't have signs and symptoms and they had one of these surgeries done, you do not have to count it as a surgical site infection. Okay? And these are the ones that are 90-day surveillance. Remember the old term, the term that we used to determine how long was implant? If they had an implant, then we had to do them for, it used to be for a year. We had to do 12 months worth of surveillance. Then they shortened it to 90 days, and now they've taken implant out of the description. So don't let that fool you. If you have someone that has a breast surgery and they didn't have an implant, you still have to follow them for 90 days. Okay? So it's not implant related any longer. Same thing for hernias. Most hernias do have an implant, but if they don't, you still got to follow them for 90 days. Question?
If you have somebody who has a knee surgery done, and they have, it's 90-day surveillance, multiple trips back to the ER for pain throughout, and then they take them back to surgery about 5 months out, they call treatment's positive. It's past the 90 days, but they started having that symptom of pain during the 90 days.
So her question was, if you have somebody that has a total knee and after their surgery they're back and forth to the doctor related to pain management, and then 5 months out they come back in and that knee's infected, that is not somebody you would count unless they met your definition of infection within that 90-day period of time. Okay? So these are the sites of organ-space surgical site infections. You can see there's a category pretty much for anything that you would call organ space. One of the newer ones is this PJI, the periprosthetic joint infection, and this is the one that is to be used for knees and hips. We used to put those under joints up here, but last year they changed that, and so this is the criteria if you have a knee or a hip infection for your organ space, and those criteria are different than the joint criteria, so make sure you become familiar with those. And then you can see all of the others up here. So, any questions before we, yes?
So if someone has a procedure done, we start that as day 1, or monitoring 30 days. If they go back in, say, the next day, in the same incision site to do another procedure, do we start 30 days from that day, or do we still start from day 1?
That's a great question. So her question is, if they have a procedure, and that's day one, and then the next day they have to go back in 24 hours later or 36 hours later, and they have another procedure, does your clock start over? It does. So if they have another invasive procedure, then your clock starts over and you move forward. Unless they were infected when they took them back, which would be a little unusual to get infected that quickly. But so you always start your clock over with that most recent procedure. Now, in the event that they have a procedure, they go back and they have an IND, and you cannot confirm that they're infected at that time of IND, so you can't write them up. And then another week passes and they have to go back and they are infected then. You do not attribute that to the surgery because they had that IND in between. Okay? So when they go back, if they have a procedure, they have to meet your definition of infection then, or you use that as your starting point moving forward. Did you have a question?
Well, that was sort of my question. So
Okay.
if I have somebody go in for a chole today, but then they go in for a bleed tomorrow, they get infected, it's not attributable to the chole. It's
Correct.
So
Correct.
I would still track it, but I wouldn't have to report that to NHS.
That's correct. So the other thing that's, and I'm not sure, there's probably not a slide in here. So if NHSN says, if they have some sort of an invasive procedure, it doesn't even mean they have to go back to the OR. This is where your breast patients come into play, because if they've had a breast implant and they go back to the clinic and they have that, I'm not exactly sure what they do with the breast implants post-operatively in the outpatient setting, but it's my understanding that they sometimes will aspirate or inject that implant. If that happens and they get infected after that, that infection should not be attributed to the surgery because they have had some sort of invasive procedure done to that surgical site. And that, I mean, to me that sounds fair. And then that does not include anything that is not invasive. So if they have some sort of closed manipulation of something, then that doesn't count. But if they do something invasive, then you would want to be able to track that.
So would that be similar to if I have a knee patient and they come back into the ER and they try to drain something and it's negative, but then like you said, they come back, so because they tried to aspirate that fluid, that counts as...
That would, so her question was if they come into the ED with painful knee and maybe they've even got some fluid on their knee and they aspirated in the emergency department, but the culture's negative and they don't meet her definition of a surgical site infection, 2 weeks later they come back infected, then you would not attribute that to the original knee surgery because they had an invasive procedure done that was provided the opportunity for an infection to occur. Okay? Yes?
What if they meet the definition with the purulent material and redness, but then they have a negative culture? That's where I got lost a little bit.
So if they meet the definition with the description of purulence, then your definition is met. You can use that criterion under superficial or even under deep if it's from the deep incision. So you can either meet that one. If you go to the second one where the incision is either dehisces or is opened, that's when you could not count a negative culture to meet that component. But the one above it, it's not all of those, it's one of. So we'll go back just a minute. Oops, sorry, going forward. So it's just one of those. So if they've documented purulent drainage from the incision, you're done. Even if they culture it and the culture comes back negative, you're still meeting that definition if they documented purulence. Okay? For the superficial. And that would be true for deep as well if it's from the deep incision. So again, it's only one of those. So it's not, you got to have purulent drainage and they got to open it, and so it's only one of those.
So they have to document some kind of purulent, milky, chocolatey drainage. So if they just say serosanguinous fluid...
serous sanguinus is not purulence. You know, usually that's some sort of blood mixed in with some sort of body fluid, but it does not meet your definition for purulence. Now, they can have infected hematomas, and that does count. If they go in and they've got a hematoma in there and they culture it, or they indicate that it's an infected hematoma and there's other evidence there, then that would count. But just the verbiage of serous sanguinus does not meet your definition of purulence.
So they can have the fever, they can have the redness, they can have the pain, but if the physician doesn't culture it and doesn't say purulence, even though he's opened it, it does not mean that.
No, so it does if he opens it and does not culture it. So it's only if he cultures it and it's negative. But if the incision spontaneously dehisces or is deliberately opened by the attending physician and is culture positive or not cultured, then it meets it. But if he does culture it and it's negative, that's the only time that it would not meet that component. Yes?
Just to make sure I understand, if purely drainage is documented, but he went in and opened it and it was negative, I could have stopped at purulent even if I have a negative culture?
That's correct. And just be careful. For superficial, that's pretty easy, because usually they're going to have drainage from the incision and they're going to describe it. And if they've described it as pussy or purulence, then your definition's met. That's true for deep as well, but the purulent drainage has to come from the deep incision. And usually that's not going to happen unless that incision has opened. Yes?
We get into a situation a lot where we have, the patient comes in, they'll have like a lot of drainage and things like that. They'll do like a CT, and then they'll get their interventional radiologist to go in and drain something.
Mm-hmm.
And just about every time this happens, it ends up culturing positive.
Mhm.
But our interventional radiologist is really sketchy about what he documents. He'll put abscess, and then he puts at his culture site as being wound. So you really don't know where it's at. But then he'll come back like with MRSA or something like that.
Mhm.
Where would you put that when that happens? Because it happens a lot at our facility.
So her question is related to if they come back in and they have to have CT imaging, they go to interventional radiology, and they do aspirate that. So if they're aspirating it and they're growing an organism, then you got to count that.
Yeah, we've been counting
Okay.
it, but at what level is kind of where we're stuck.
So I think, so at what level do you count it? I think if you need to try to determine at what level he went in, whether it was just below the fascia, and hopefully on the CT he's provided some information as to where that abscess might have
It's really
been.
sketchy.
Yeah.
He'll tell where he's done like the lidocaine, and he usually says down to the subcutaneous tissue, and then he says he drains, but you don't know
Okay.
where he got it from.
So if I couldn't tell, I mean, can you tell if he goes below the subcutaneous tissue?
He does not document anything like
Okay.
that. He just says that he pretty much does the lidocaine and everything to the subcutaneous tissue. He inserted the needle and aspirated, and he'll say like purulent drainage. This is what he'll put in there.
Yeah, I mean, given that scenario, I'd have to think that it would be at the subcutaneous level,
That's what we've been doing. We were just making sure we were.
Right, because usually if it's deeper, they'll say fluid collection in the pelvic area or the peritoneal space or
Usually he'll do
intra-abdominal.
that. If it's
Right.
peritoneal or something like that, he'll do it.
Right.
It's just, we find this a lot when it's something that's surgical site that's maybe more superficial. So that's what we've been calling it superficial. We just
Right.
wanted to verify.
Right. So her comments were if your CT doesn't confirm the location of the fluid collection that they're aspirating, what do you call it? And if I had any doubts, I might check with the interventional radiologist, but pretty much if he's saying it's subcutaneous, I would call it superficial. And again, that would have to meet your 30 days. It doesn't matter. A lot of people look at those procedures that you can go out 90 days on, and if they get infected, they want to call the superficial because you're doing surveillance for 90 days, but you can still only count superficial for 30, regardless of the procedure. Do you have a question, Jennifer?
We had a case recently. It was a that laminectomy came in, surgeon documented in the operative note, deep wound, did not document purulent drainage, but documented, it was deep, incision was open, they grew the culture, the patient had localized pain and tenderness. I can't do anything until I get that culture back, correct?
That's correct. So her scenarios, they had a laminectomy, patient had to come back in, go back to surgery, be reopened. The surgeon documented that there was, did he say infection?
He said a deep wound
Deep.
infection.
Deep wound infection. And the patient had these signs and symptoms, and he did culture him. So we need to wait and see if that culture grows anything.
But if he did not culture the patient, it still would have been.
If he did not culture the patient, you would have met your definition. And that patient's probably going to grow something, I would think.
Yeah.
Any other comments or questions before we move on? Okay, great. Those are good questions. Okay. Okay, so case study number 1. Everybody have their clickers? Did we pass those out? Yeah, okay, cool. So we've got a patient that's admitted with a ruptured diverticulum and a Coley procedure is performed in the inpatient OR. The case is entered as a wound class 3. There's a specimen that's obtained in the OR which later returns positive for E. coli. The surgeon staples closed the skin at 4 locations with packing placed between the staples. It's pretty straightforward. They have a ruptured diverticuli and they have a colon procedure done. So, is this procedure primarily closed for 2015? Yes or no? Oh, good. You guys are on the ball this morning. Okay, so let's see what you thought. 95% said yes, and yes is the correct answer. Remember, if there's just one place where the skin edges are approximated, is considered to be primarily closed. Now, just a note on that, if they close the tissues and the fascia, but they leave the skin open, the skin is our determining factor. So if they leave the skin open, that's considered to be non-primarily closed, even though they closed it at the fascia layer.
What about if they have a wound vac?
So if they have a wound vac placed at the time of surgery, and are any of the skin edges approximated? If any of the skin edges are approximated, then it's considered to be primarily closed. Even with a wound vac, even if they've got drains coming out of that incision or anything else. So case study 2, we've got a patient admitted with an acute abdomen. They go to the OR for an exploratory lap and they find an abscess due to a ruptured appendix and they perform an API. The patient returns 2 weeks later and meets criteria for an organ space intra-abdominal SSI. So does this procedure meet the criteria for pathos or present at time of surgery? Okay. Good job, yay. You'd be surprised if I put no up there, wouldn't you? So, good job. So the second question for this then, whoops. Oh, we had a second question. I think the second question was, would this be reported as an SSI? When they came back 2 weeks later, everybody nod yes? Yes. Good. Okay. Maybe that was up there. That question was up there. Okay, never mind. My mistake. So case study number 3, we've got during an unplanned C-section, the surgeon nicks the bowel, and there is contamination of the intra-abdominal cavity. 1 week later, the patient returns and meets criteria for an organ space, other reproductive, surgical site infection. Pathos is checked as yes. True or false? Okay. See what you guys think here. So, good job. 80% got it correct. It is false because that nick was a complication at the time the surgery was being performed. There was not evidence of infection preoperatively or intraoperatively. That was a complication rather than an infection present at time of surgery. So this is something that NHSN put on their thing. On the subject of surgical site infection reporting, one of their users emailed, could you help us with the definition and some examples of stab wound infection? Does stab mean laparoscopic or like a street fight and an ice pick is used? So I'm sure they have to have a little bit of humor down in Atlanta. So we actually meet their needs, right? We send them some emails that they can chuckle over. So case study number 4, we've got a patient that had a colon and a hysterectomy through a single incision during a single trip to the OR. They make the incision at 8:23 and the procedure finish time is 11:33. The OR report also indicates that the hysterectomy part of the procedure began at 10 o'clock. So we'll let you look at that a minute. So which one of the statements is correct? Only the colon should be reported since it is higher on the priority list. 2 separate procedures should be reported, the chole with a duration of 1 hour 37 minutes and the hysterectomy with a duration of 1 hour 33. Or 2 separate procedures should be reported, 1 for colon, 1 for his, each with a duration of 3 hours and 10 minutes. Okay, so let's see what you guys think. So 62% believe that 2 separate procedures should be reported, colon with a duration of 1 hour 37 and a his with duration of 1 hour and 33. And then about a third of you thought number C, and the correct answer is number C. Remember, if they use the same incision, then we use the same start and finish time for both procedures. So the key word there was the same incision. Okay? Just trying to get, so I can see the case studies. Any questions about that? Yes?
This be for the denominator,
I'm sorry, yes. His question was, is this data for the denominator? And that is correct. You would report.
If there was a surgical site infection, would you report it of the colon or the history?
That's a great question. Let me just get these case studies out. Get this out of my way before I drop something. Okay. So his question was, if this patient had a surgical site infection, which surgery would you report it for? So the NHSN's directions on that, if you can identify, based on your documentation, of what surgery the infection was associated with, if it's clear, and I have had a couple of cases where that was true, where you could actually discern from the operative note where that level of infection occurred. If you cannot, there is a priority list that NHSN has as part of their SSI protocol module, and you would go by that priority list, and in this case, it would be the colon. The colon, small bowel used to be above colon on the priority list, but after we started sending colon data into NHSN, I think they were able to get more information on the prevalence of surgical site infection, so they bumped colon higher than even small bowel. I think liver surgery might be at the top of that priority list, and colon, I'm sorry? Yeah, and then colon is second. But in this particular patient, you would report the infection out as a associated with the colon procedure. So this is just reporting review instructions. If procedures more than one is done through the same incision, create a record for each procedure and use the duration that's recorded in the operative record for each. There is an exception if the patient has both a CB-GC CABG and a GB-GB during the same trip, only report the one. And that's because of the layers and exactly what they do on those procedures. So case study number 5, on February the 18th, we have a 45-year-old male admitted and had a laparoscopic left hemicolectomy. On the 24th, he's got purulent drainage at the trocar site. They take a culture, and it's positive for Enterobacter and E. coli, and they start the patient on antibiotics. So what should be reported to NHSN? Nothing. The surgeon did not open the wound, so the criteria are not met. Nothing. It is an SSI, but not an HAI. Or is it surgical site infection superficial incision primary, or surgical site infection deep incisional primary? Okay, let's see what you think. So 85% think it's a surgical site infection, superficial incisional primary, and yeah, you're right. Good job. Anybody want to express a difference of opinion or has a question about why we called it that? So number 6, we've got an 18-year-old female admitted for a ruptured spleen secondary to a motor vehicle accident, and she's taken urgently to the OR for an exploratory lap. She has a splenectomy and distal that one performed. And on 2/8, her post-op course is uneventful and she's discharged home. On 3/6, she's seen in the ED with a 1-day history of yellow, foul-smelling drainage from the incision, and the CT is positive for right upper quadrant fluid collection. On the 7th, she's taken to the interventional radiology for abscess drainage and drain placement with 50 cc's of purulent material obtained and culture positive for E. coli. Does our young lady have an organ space, intra-abdominal surgical site infection? Does she have a deep primary incisional surgical site infection? Or does she meet the criteria for a surgical site infection? Okay, let's see what you think. So 32% thought she had an IB, 47% thought she didn't meet the criteria, and 21% thought she had a D. Well, actually, she did not meet the criteria, and does anybody who got that right want to say why? It was greater than 30 days. So this is a great example of why the definitions, you know, are standardized. Sometimes, obviously, this young lady got an infection, right, from her surgery. It's not one we will report because it didn't meet that standardized definition. So, on the other hand, when we have to call some that we aren't convinced that they were true infections, so there is some overcall and some undercall, but that's why we have those standardized surveillance definitions and not clinical definitions. Good job. So this is the 30-day surveillance, just as a reminder, and you'll see that spleen and pancreas surgery are 30-day and not 90. So on case study number 7, we've got a patient admitted and underwent a hemicolectomy due to colon cancer. On the 14th, they spike a fever, have abdominal pain. Their ultrasound shows an intra-abdominal abscess. They go to the OR for an IND, and they collect a culture that is positive for E. coli. And then 3 or 4 days later, they're able to be discharged home. So what do we think he has, or she? Do they have a surgical site infection that's superficial, incisional primary, a deep incisional primary, an intra-abdominal, or a GIT, which is the gastrointestinal tract? Okay, let's see what you think. So 61% think it's an IAB, and that is correct. So when they're organ space and you identify that organ space criteria that's met, then you report it out like this, SSI IAB instead of organ space IAB, okay? So good job. And then what if in this particular patient, remember they had the abscess and they went back and had the IND, What if at the time of the IND, the surgeon discovered that the patient had suffered an anastomotic leak, and that's why the abscess developed? Would it change your determination of an SSI-IAB? Yes or no? Okay, let's see if you think it makes a difference. Good. No, it does not, even though that is what we see oftentimes in colon surgeries. When we take them back and they've got an infection, they had a leak, and that's why they became infected. We still have to report that out as a surgical site infection. That's a good data element to capture, to feed back to your surgeons, but it will not impact whether you call it a surgical site infection or not. Okay? So case study number 8, we've got a patient admitted with an acute abdomen. They're taken to the OR for open appendectomy, and the wound class is 3. They're readmitted 2 weeks later, post-op day 21, have fever, abdominal pain, CT evidence of 2 intra-abdominal abscesses. They drain it and get 100 cc's of purulent drainage that's positive for E. coli and Bacteroides. So our patient meets criteria for an organ space IAB SSI, but should not be reported because the case was contaminated at time of surgery. They meet criteria for deep SSI. They do not meet any criteria because the surgeon didn't say they were infected, or the case meets criteria for organ space IAB and should be reported as attributed to the API. Okay, we're going to see what you think. So 19% believe that it should not be reported because of the wound class was 3 at time of surgery. 69 believe that it did meet the definition, and that's correct. So it really doesn't have any impact on what the wound class was. The only thing the wound class tells us that is that they may be at higher risk for getting an infection, but it doesn't negate the need to call it a surgical site infection if they do become infected. Try to get through these last few. So Mr. Jones had a hemicolectomy performed on April the 1st. The duration of the procedure was recorded as 3 hours and 10 minutes. Later that same day, his abdomen was rigid and he became hypotensive. He was taken back to the OR urgently and had repair of a bleeding vessel. And this surgery time was 1 hour and 15 minutes. So when we report that colon to NHSN, you should report the colon procedure with a duration of 3 hours and 10 minutes. Do not report the procedure because the patient had a complication. Report the colon with a duration of 4 hours and 25 minutes. Report the colon and the other separately with the appropriate OR times. Okay, let's see what you think. So 73%, got it right, yay. So you add those 2 times and you do not report that second procedure because it occurred through the same incision within that 24-hour period. So if you know they took them back, just add that time to your colon procedure. So this is the reporting review instructions. Oh, so you do assign the wound class or the wound closure method that applied to the original procedure. So if they closed them the first time but left them open the second time, you would indicate closed for that. Case study 10, you've got a patient with bilateral knee prosthesis implanted during a single trip to the OR. The left knee procedure start time was 8:30 with no recorded finish time for that knee. The right knee was recorded for procedure finish time as 11:30 a.m. So 8:30 to 11:30. Would we report one knee procedure with a combined duration of 3 hours, 2 separate, each with an hour and 30 minutes, or 2 separate, each with a duration of 3 hours? Okay, so 75, almost 75% got it right. You would, because you didn't have a finish time, you would take the start and the finish time and divide them equally among those 2 knee procedures. I think this is our review for that. And then our last case study, we've got a 36-year-old retired hockey player admitted and taken to the OR for total knee replacement. His post-op course is completely uneventful. His incision is clean, dry, and intact. He's discharged home with outpatient physical therapy. On the 16th of February, he's working out in his backyard, slips and falls. The incision opens and the patient cleans the area and places a bandage on it. On the 19th, they note redness, increased pain and tenderness, with greenish yellow drainage at the site. They go to the ED and get admitted. On the 20th, they're taken back to the OR and purulent fluid is noted tracking down to the prosthesis. Fluid is sent for a culture, and the knee was irrigated, and the culture from the OR is positive for MRSA. So he had his surgery, he's doing great, he falls at home. He comes back in and has to go back to the OR. So the patient does not meet the criteria for surgical site infection because the incision was healed at the time of discharge and the patient fell at home. The patient has a deep SSI. They have an organ space, periprosthetic joint infection, SSI, or they have a superficial primary incision, SSI. So 60% thought it was an organ space PJI, and that is correct. Okay, so last year or year before, they, in surgical site infection, they did say that if something like this happened, you did not have to call it a surgical site infection. And then they changed it again. So now we do, regardless of what happens after they have that procedure, you know, whether we can't base it on how their environment is at home, what their hygiene status is at home. If they get an infection after that surgery and it meets our definition and it's within that surveillance period, then we have to count it. Okay? Same thing's true for if you have an elderly person with a broken hip and they go to the nursing home and there's evidence that that wound was contaminated with urine, or they even fell out of the bed at the nursing home and the incision opened and they get infected, unfortunately, we still count that as a surgical site infection. Okay. All right, so our time is up. Any quick questions? You've got some additional case studies. I tried to put some extras in there to give you guys an opportunity to work on them if we didn't get through all of them in here. So we will take a
You guys want to take like a
stand-up break or,
5-minute break?
right.
Go fill up your coffee, go to the bathroom. We'll come back in, hit it again.